Welcome back. Today we'll be covering the histology of the salivary glands and the pancreas. The salivary glands are going to be your exocrine glands, and there are three of them. The parotid here in the cheek is going to be the largest one, the sublingual beneath the tongue, and the submandibular below the jaw. And they're all located in the connective tissue below the epithelium lining the oral cavity. And they all have glands depending on where they are. They have the labial, which are like in your mouth area, the palatine, and the von Ebner's gland. And here is the circumvent papilla with the von Ebner's glands. If you recall, the glands secrete kind of mucus solution, a serous solution, to wash the taste buds to prime them for the next gustatory sensation. So these salivary glands don't have any capsule. All they do is make the saliva. There are large glands that have septa, and then those separate into these lobules. And the myoepithelial cells are going to be found between the basal surface of the acinar cells and the basal lamina around the duct. And here's the duct. Here are the serous cells on the edge, the mucus acini, and then there are going to be the canaliculus, and this is the mixed acini. So in development, first it's like innervated, and it grows in and then follows the path of the lobules, and the epithelial cells are the serous cells, which are like kind of pyramidal, round-ish, and they have a centrally located a nucleus and a well-developed rough endoplasmic reticulum. They're all kind of joined with each other by these tight junctions, and they make the acinus with the central lumen, and they are polarized. So on one end there's going to be more like rough ER, which is in the basal region, and on the apical end there are more secretory granules. The mucus cells, on the other hand, are columnar, and they're organized in tubes. These are polarized, and they are going to have one end. The basal end has the rough endoplasmic reticulum, the nucleus, and then the apical end has the mucin secretory granules and a very defined Golgi apparatus. So as you can see, there is some kind of like a pattern. The apical region always has the secretory granules, which makes sense because that's where they are secreted from, like the tops of the cell. The bases of the cells are usually like adherent to the lamina propria or the basement membrane. Okay, so the ducts. There are a couple different kinds, the intercalated and the striated ducts. And they don't have a lot of connective tissue, as you can see. They're all pretty crammed in there. The intercalated ducts are going to drain the individual secretory units. These are going to be lined with the cuboidal epithelium, and those add bicarbonate to the saliva. And the striated ducts are going to be columnar cells, and they are infoldings of the basolateral cell membrane and numerous mitochondria. Inside of them make this striation, and those cells can absorb sodium and secrete potassium ions to buffer the saliva, because remember the cuboidal end will add the bicarbonate. IgA is going to be made by the plasma cells, of course, in the connective tissue around the intralobular duct. They're going to be taken up by the serous acini and released into saliva. The intralobular ducts are going to drain into the interlobular duct, and all of those are excretory ducts, and they're embedded in the connective tissue. So interlobular are going to surround the lobes and lobules. Intra is inside. So these are going to be aligned by either simple or stratified cuboidal or columnar epithelium, and the pseudostratified epithelium. So the main duct's epithelium is replaced by the stratified squamous as it goes into the oral vestibule. So they kind of start off with like taller cells and they get flatter, and then you get squamous epithelium. So the parotid gland, the one in the cheek, is the largest one, and it only makes a serous solution. It secretes the alpha amylase and the lysozymes to break down carbohydrates in the mouth, and they're defined by these like very large and very prominent striated ducts. These ducts are pretty big, and they have a lot of adipose tissue surrounding it, and really depending on the face. Some people have a lot of buccal fat, some people don't. Oh, if you can recall, like this artery from anatomy is going to be like your facial artery. So the submandibular glands are going to be the ones below the jaw, and it's a mixed serous and mucous gland, and the mostly serous though. And the mixed acini have a little cap on it, which is like a demilune of myoepithelial cells, and those will also secrete amylase and lysozyme. And the ducts, like they secrete it, go down through the intralobular ducts into the interlobular ducts, and then they are released through the striated ducts. There aren't as many intercalated ducts and striated ducts as the parotid gland, and in cases of rabies, there's going to be an overproduction of watery saliva, which makes the frothing of the mouth. So the sublingual glands are the ones beneath your tongue, and these are also a compound gland, but this one has the more mucous acini, while the submandibular gland has more of the serous acini. So the serous cells are only on the demilunes, once again, as these little caps. And this one has absolutely no intercalated or striated ducts. So what is saliva? Saliva is a mix of enzyme and mucus, and it has several functions: swallowing, digesting. The IgA will limit the bacterial growth, and it has a high bicarb content, of course. The production is stimulated by the parasympathetic system and inhibited by the sympathetic system. It's stimulated by like smells too. Atropine will block the parasympathetic action, and that's usually used to treat like salivaria, which is overproduction of saliva, and there is going to be xerostomia, which is caused by radiation or antihistamine. This is also dry mouth, which doesn't sound too bad. You're like, oh, what a problem to have dry mouth, but it's actually pretty terrible because the entire oral cavity, along with the throat, like down to the esophagus, is going to be very uncomfortable. These people aren't going to be able to like eat because it's so painful. All of the mucosa is kind of like exposed, and remember, the mucosa is only covered by non-keratinized pseudostratified epithelium, and it's going to rub and it's going to hurt, and these people aren't even going to be able to swallow normally. Okay, so moving right on to the pancreas. This is going to be your exocrine and endocrine gland. It's covered by a thin capsule of loose connective tissue, and that invaginates in to make the septa. And the lobules are going to be made of the exocrine secretory axini, the duct system, and the islet of Langerhans. The exocrine secretory axini is covered by this delicate sheath of reticular fibers, and it's problematic because it's quite delicate. So in pancreatitis, there can be a rupture of the fibers with the rich capillary network, so it can bleed out quite easily too. The islet of Langerhans are these like kind of lighter, stained, spherical masses, and those are your endocrine cells. And you can barely see, but they're covered by a thin reticular capsule. The compound acidic glands are just going to be serous glands. There are no adipose tissue or myoepithelial cells found in the pancreas. So if you see like a fatty pancreas, that's clearly a sign of a problem. The serous acini are going to be irregular clusters, and they're around like a smallish lumen, and that is drained by a short intercalated duct. And the pancreas makes a lot of pancreatic juices because these are used for digestion. So the acinar cells are going to make like proteases, and those are going to be inactive zymogens. Why is that? It's because the pancreatic juice has to drain into the duodenum, and if they're already active, it's going to eat away at the duodenum. So they make all of these. Okay, so the duct system begins in the lumen of the acinas, and it's first like lined by a central acinar cell, and that's only in the pancreas. And then the intercalated ducts are going to be lined by the simple cuboidal epithelium to make the bicarbonate, which is going to make the enzymes like zymogens, so they're inactive. And those will merge into the intralobular ducts, which are lined also by simple cuboidal epithelium, and then those drained into the interlobular ducts. Interlobular ducts, okay, so like things are starting to change. It's lined by simple columnar epithelium instead, and it joins the main pancreatic duct, which is lined by tall columnar epithelium. So it just gets like taller because there are more. It has to drain more fluid, so these cells need to be a little bit more robust. So it drains into the duodenum with this like herringbone pattern, and there is a main duct, the duct of Versing, and the duct of Versing is the one that has the tall columnar epithelium. And then it goes into the hepatopancreatic ampulla of Vater, and there's also this bile duct. Sometimes there's an anastomosis, but usually there isn't. Okay, so pancreatic cancer is rare, but it's deadly because we often don't catch it on time, because not everybody like suspects pancreatic cancer the minute they have like hypogastric pain or whatever. We kind of assume that it's more common cancers like stomach cancers, like duodenum obstruction. We don't just jump straight to pancreatic cancer because like the only way you can really tell is to do a biopsy of the pancreas. And usually 80% of them are adenocarcinomas of the duct system, so something's going wrong with the cuboidal or the columnar cells, and they're just non-specific symptoms. I mean, you don't go into the hospital because of fatigue and well, like some people do, but the non-specific symptoms like fatigue, sometimes the headaches, like sometimes it comes, sometimes it goes, sometimes you have stomach pain, sometimes you don't, and that can all also be chalked up to like GERD. So unfortunately, by the time of the diagnosis, 50% of the patients have like the metastasis to the lymph nodes in the lung, and it presents with painless obstructive jaundice, but like that's when like the pancreas is kind of shot by that time. Here is the pleomorphism. So all these cells are part of the tumor, and look, there's not really any organization. There's just like a bunch of cells. So pancreatic juice is alkaline fluid, and it drains into the duodenum, like I said, through the duct of Versing and through the ampulla of Vater. Like I said, these enzymes have to be inactive, because if they are active in the pancreas, they can cause inflammation and autodigestion of the pancreas itself. Acute pancreatitis can be caused by like gallstones, trauma, infection, and alcohol abuse. In the duodenum, that's when the enteropeptidases will cleave the inactive trypsinogen into trypsin, and then trypsin is the magic like key. It activates all the other zymogens, such as trypsin, chymotrypsin, carboxypeptidase, and those will work to hydrolyze proteins. The ribonuclease, and they'll split the nucleic acids. Amylase, starch and glycogen, pardon me, and lipase will hydrolyze the triglycerides, and cholesterol esterase, of course, will hydrolyze cholesterol. Okay, so cholecystokinin will stimulate the acinar cells to secrete the enzymes in the proenzymes. Secretin will stimulate the duct cells to secrete water and the bicarbonate. And then the parasympathetic fibers in the vagal trunk, so cranial nerve number 10, will apply low stimulus to the acinar cells and the ducts in response to anticipation to a meal. So, when you're hungry and you already see the meal in the restaurant and you smell the food, this is going to help the response of salivating, and this is also why when you're hungry and you see food, you can feel your guts like rumble or move around. This is the anticipation. Okay, so this is the endocrine portion of the pancreas, and that's involved with the islet of Langerhans. And those are more in the tail. The cells are going to be sort of rounded and lightly stained. They have cytoplasmic granules, and they really only can be distinguished from one each other using the immunohistochemistry. All of these are sort of the same. You look at this and you're just like, oh, that's just the islet of Langerhans. The beta cells are the most common. They secrete insulin. Alpha cells will secrete glucagon. Delta cells are pretty rare, and they secrete the somatostatin, which will influence glucagon secretion. And the pancreatipeptide cells will secrete the pancreatic polypeptide, and those are very rare. Those are just kind of scattered within the islet itself. We're honestly not really sure about what the specific function of the polypeptide does. We just know it has some kind of role in digestion. Okay, so that's it for now. Thank you for your attention, and good luck studying.